All right, so pacers and paced rhythms. So we've talked about bradyarrhythmias, from sinus brady to AV blocks to junctional rhythms to idioventricular rhythms. And the treatment for all bradyarrhythmias is, yes, atropine at the beginning, as long as the AV node still works. The next step after that, yes, epinephrine, isoproterenol. But then after that, it is pacers, right? And the pacers can be temporary, right? So there's a transcutaneous pacing. This guy's on a transcutaneous pacer right here, which is slapped to the chest, and we're going to pace through the chest wall. And then there's transvenous pacers, where we go in via a large vein, usually femoral vein. We're going to go in, and we're going to end up in the heart, in the ventricle right there, the right ventricle, and we're going to pace it internally, right? And then if they can't get over their current issue that's caused them to be bradyarrhythmic, so it wasn't a drug overdose. We tried glucagon. We tried to, wait it out because they took too much of the beta blocker at home, and then it's just now still this profound idioventricular rhythm. And so the next step is to do a permanent pacemaker, right? So a PPM, or permanent pacemaker, that's going to be implanted, right? These in the 90s, they used to have a lifetime guarantee, meaning they lasted 5 years, right? So that used to be what it was, but now we have generator changes where we change out the battery, right? Every 5 years or so, 5 to 10 years. So we have this little generator that's going to generate a impulse, right? And it's going to fire down, and it's going to cause a depolarization. Is it the normal pathways? No, it's starting from Venice Beach, right? And it's going all the way up the little side streets, all the way through LA, and going to depolarize it, not via the 405 and 5 freeway, but via all little side streets. You can get depolarization. So therefore, it's going to take a long time. So you can see your QRS is prolonged. Every paced rhythm has prolonged QRSs, right? And how you know it's not idioventricular, because idioventricular rhythms have wide QRSs, it's because you see this generator spike. You see the spike on there. That's what initiated the complex, right? That's what initiated the QRS, or it can also initiate the atria, right? If it's initiating the atria, what are you going to see? You're going to see a P wave, right? So that's going to initiate the atria, P wave, and then you have the V, right, which is the ventricles, right? So you have atrioventricular pacing, right? You have AV pacing or just V pacing. Those are the different varieties of pacing you can do, okay? So we have different types of pacers, transcutaneous, transvenous, and permanent, right? That's where they definitely need this. They just, with age, their AV node has died, right? So we have to replace it with a permanent pacemaker. And then the next step after we put the pacer in place is what can happen if the pacer generator is at his lifetime, right? Is at 5 years, 8 years? What happens if the lead is fractured, right? This little lead can fracture, right? What if that happens? What if there's scar tissue that develops down here at the base, right? That's going to be a inadequate impulse getting to the ventricle, and you're going to get inadequate capture of the heart. So those are our 3 different problems that can happen: failure to pace, failure to capture, and failure to sense. So we'll go into detail on those guys. So this slide summarizes all the different modes and all the different methods of pacing, right? So there's different modes of pacers, right? When they put this little generator into the patient, right? There's all kinds of different things that can happen, and we can change many different settings to figure out, do we want to pace the atrial ventricles? Do you want to inhibit the atrial ventricles? Do you want to don't worry about it and just pace automatically? So that's the modes that we're worried about, right? So modes are, you're looking at what is being paced, right? And the other thing is we're looking at sensitivity of the pacer, right? So the pacer is able to see what's going on. It doesn't have little closed circuit TVs. It's sensing electrical activity from the heart. And we can change what's called a little fence in here. We can increase it up and down. We can change the sensitivity of the pacer so it can see activity or not see activity, right? If the fence is too high, we can raise this fence even more. Goes even more. Is it going to pace? No. It's just going to say, whoa, there's no activity, therefore I didn't do anything, right? And same by vice versa, the fence can go down too far and it can overpace way too much, right? So we are looking at the ventricles or the atria. There's different things that the pacers can do. And it can get pretty complicated. There's a whole field of just pacemakers. There's Boston Scientific. There's different fields that do all kinds of workings with permanent pacemakers and such, right? So it's all based on the sensitivity, right? about 0.2 to 10 millivolts. It's assessing the millivolts. It's about how high your fence is. So the fence is at 10 millivolts, it's not going to see anything. If it's at 0.2 millivolts, it's going to see too much. So that sensitivity can be adjusted, right? You can raise the sensitivity or lower the sensitivity. And it gets weird and it's difficult to understand because is it high sensitivity or low sensitivity? Is it undersensing or oversensing? And we'll get into the details on that, right? But it's basically what does the pacer see? Does it see the activity or not, right? And when you're looking at pacers, you can think of the mnemonic pacers, right? So PA stands for what chamber is being paced. So is it the atria being paced, the ventricles being paced, or is it both of them, right? So we have AV pacers, V pacers, A pacers, right? Or dual chamber pacers are the ones that pace the atria and the ventricles. We're going to see two spikes on our EKG complex if we have AV paced, right? So that's what the first thing you look at is what is being paced, right? Is it the atria or the ventricles or both of them, right? So the next step is what is sensed with a CE. It's the only thing I can get it to mnemonic wise, right? So yeah, you could say SE, but it's what is sensed, right? To make the pacer mnemonic work. So we have what is paced and what is sensed. So are we sensing the atrial activity or are we sensing the ventricle activity, right? And so that's going to tell the pacer what to do. When I sense ventricular activity, what do I do? If I sense it, if I say, whoa, shoot, they just had a little QRS. Should my pacemaker go off? Probably not. It's going to say that they got a good rhythm going, right? They're doing their own thing, and it's only going to kick in if it does not sense the ventricular activity. So for instance, they're set at different rates, like a rate of 40 or 50, and if the rate gets too low, it says, whoa, I didn't sense a ventricle. What am I going to do? Well, one, I'm going to intervene upon the ventricles, and I'm going to do something based on what I didn't sense. I'm going to do what's my response to that. My response is either going to conduct, and it's going to send an impulse down and going to hopefully capture and contract the ventricles, right? So we have what's paced, the ventricles, and what is sensed, the ventricles. Like, oh, I didn't see anything. Well, where's that QRS at? I didn't sense anything. What's my response? My response is either to trigger or do something, right? And so the I inhibit was, as our one mode, was what we talked about in the first scenario. The heart rate's 75. They got QRS complexes. I pace the ventricles. So what I pace is ventricles. What I sense is ventricles. And look at that. You got a QRS. Go, attaboy. And then what's the response was I, inhibition. It says, well, I don't need to kick in because there was actual ventricular response, right? So trigger is where you are actually triggering the ventricles. You're actually doing something, right? So you are getting some activity out if you don't sense anything, okay? So there can be problems with this. There can be problems with sensitivity, and that's what we're going to look at on the next slide. But going back to this is the primary modes of your of your pacemaker. It's about as complicated as a ventilator, right? So it's looking at what is paced or what can pace, and it's going to see what am I looking at? What am I sensing? I'm sensing either the ventricles or the atria, or I'm working on both, right? And what am I going to do when I see that activity, right? Which is what my response is to what is sensed, okay? So the other mode here you'll notice in red is O. O means that it's going to be nothing is sensed, doesn't care actually. It's going to pace the ventricles. It could pace the atria too, but it's pacing the ventricles, doesn't care what the ventricles are doing. It's going to say, I'm not going to sense anything. All I'm going to do is pace no matter what. That is what is called VOO mode. So V for ventricles, O for what is sensed, nothing, O for zero, right? I'm not sensing anything, and O is only in conjunction with that. So VOO mode is when there's ventricles are what are going to be paced no matter what, right? So that's how they get these different modes, VVI, VOO, DOO. There's all kinds of different modes where they can interact with these three settings, right? There's three letters, and each one means something, right? The first letter means what is being paced. Is it the atria, ventricles, or both, right? Both being D. They should say D. It should really be a B instead of D, because D is dual, right? So is it the atria being paced, the ventricle being paced, or dual, or both being paced, right? And the next letter so that's letter 1. Letter 2 is what is being sensed. Am I sensing the ventricles, or am I sensing the atria, or do I not care? right? If I don't care because I'm going to pace the ventricles, which was the first letter, no matter what. If I'm pacing no matter what, that's actually called VOO mode, and that's just going to, we're done after that point. VOO mode is for an emergency, right? So when you don't care about what's going on. And then if we do care about what's going on, we look at the ventricles, we pace the ventricles, we're looking at the ventricles, we're sensing what the ventricles are doing, and the next step is what happens when we see ventricular activity. When we sense ventricular activity, with that second letter there, what happens? So you can see here in this mode, VVI, we inhibit the pacer. So when we see ventricular activity, when we sense it, we are not going to pace. So that means that the heart rate is good, right? Heart rate's more than 60, more than 75. What are the manufacturer, what are the cardiologists decided on for this patient? That is that mode. And VVI mode is one of the more common modes, right? Where you are pacing only when it's needed, right? So VVI says only pace when the heart rate is greater than less than 60, for instance, or less than 50. Okay, is that clear as mud? Is that how that works? So it's three different letters. It's what is being paced, what is being sensed, and what happens when we sense something. Okay, so the two big modes I want you to know are VVI and VOO. Those are the two huge modes that are the most common. And it can get complicated when you introduce the atria into this picture. It's like, well, what happens when I see the atria activity too, right? So it gets more complicated more down the road, and that's why there's a whole field dedicated to this. And engineers go to college and come out of school to work for Boston Scientific or a pacer company, right? Because you can do other things. You can sense or inhibit or sense or pace the atria, but not the ventricles and the atria both, or inhibit both. It can get really, really complicated. Okay, so those are the basic modes of pacing, right? The next step is, how do I pace it? How do I pace them? With transcutaneous pacing, with transvenous pacing, right? Or with a permanent pacemaker. Those are three different ways to pace, right? So what we're talking about was the permanent pacemaker. That was kind of what they're going to be set and forget, and hopefully they're going to come back. You know, if they have symptoms, they'll come back and get their pacer interrogated to see if the pacer is still working or not. Okay, but our first step, if someone comes in, they got chest pain, shortness of breath, hypotension, confusion, you throw them in the monitor, they're super bradycardic, and whether it be idioventricular, junctional, or whatever, it's just a low rate. We throw them on the transcutaneous pacer, right? And we pace them through their chest wall. It's a lot of millivolts, a lot of milliamps that are going to be throwing through that chest wall to try to pace them, right? If they're having chest pain and shortness of breath and the heart rate's 32, do we say, oh, let's see if the ventricles are actually working or not? We don't care what the ventricles are doing at that point. We are going to put them in VOO mode, which is what the default mode of this guy is, right? It's in VOO mode when we turn the rate on this machine up, right? If you turn that rate down a little bit, down to like 40, that means it's going to actually not do anything. When it senses ventricular activity, it's going to say, well, you got a heart rate that's greater than 50 or greater than 40. I'm actually going to be in VVI mode until you want me to be. So just changing the rate actually changes from VVI to VOO mode. Okay, so it's temporary. That's why it's called a temporary, or a transcutaneous pacer is temporary. A transvenous pacer is temporary, and hopefully it lasts, we can get them turned around with reversal agents, or figure out, oh, you got ischemia happening, or you're super hypoxic. Let's get that fixed. Maybe that's the reason for your bradycardia. But it's very uncomfortable. Every time they are getting paced by this machine, they're saying, ow, 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 ow. At whatever rate you set on the machine down here, whatever rate you set down here, R for rate, that's going to be how many times your patient's saying ow. Okay? If they're altered and out of it, and they're like actually they're super sick, they might not say it, but it's uncomfortable, right? The milliamps on this is set up pretty high, right? So we set the milliamps and we set the rate for this guy, right? So milliamps, so we set like 60 milliamps, 70 milliamps. You're sending voltage through the chest wall, through the muscles, through the bone, through the sternum even, all the way through the heart muscle and all the way through to the other side. If you have it, anterior posterior, we have some varieties where you can just do, on one side, of the lateral chest and the other side. So as long as you're getting a good conduction through the heart and you get good capture of the heart, that's what we want. Okay, so these modes again, VVI or VOO, it's just basically depending on what the rate is, right? So if your rate is set at 100, you're like all the way to, I want you to pace for every heart rate that's less than 100, I want this thing to pace this patient, right? So pretty much you're in VV what, or VVI or VOO mode. If your heart rate's, if you set the rate to 100. You're in VOO. You're pacing no matter what until it gets, technically, yes, that's VVI up to 100, but really you're really pacing no matter what. You don't care what the ventricles are doing underneath. You are pacing them no matter what, right? So that's VOO mode. Okay. If they were to get a heart rate more than 100, then yes, then technically it's in VVI mode, right? So you got VOO and VVI. Those are the two modes that this pacer does, and it basically changes based on whatever heart rate you change in the corner down here. Whatever heart rate you change there, say I want you to pace this patient whenever the heart rate gets less than 40. So when it's less than 40, it's in VOO mode. When it's greater than 40, it's going to pace the ventricles. Right, that's the first letter. The second letter was what it's going to sense, which is the ventricular activity. It's like, oh, hey, I saw, look at that. They got a QRS that's greater than, with a rate that's greater than 40. And what's it going to do with that? It's going to inhibit the pacemaker, right? So it's going to be in VVI mode when the rate is greater than what we set. So that's transcutaneous pacing. And then transvenous pacing is when we want to continue pacing, they're not getting better. So it's been more than 2 hours, more than 4 hours, right? They've been saying ow for 4 hours straight. You need to call somebody, and this is usually a cardiologist that's going to place a transvenous pacer, right? And the transvenous pacer goes in, and it's going to sit right there in the right ventricle, and it's going to pace at whatever rate we set, right? And it's the same thing. It's going to be in a VVI mode or VOO mode, okay? So we set it we change the rate so that it's pacing them no matter what. And you can get really fancy with these guys too and start getting into permanent pacemaker territory with the transvenous pacers, okay? So it's someone who's symptomatic bradycardia for more than 2 hours, and it's going to require less milliamps because you're not going through the chest wall with muscle, fat, adipose, etc. It's just right there, right inside the ventricles. So it's less milliamps. Are they going to say ow? No, they're not going to feel it at all. Right, so it's going to be just their heart's beating at whatever we set this little box to, okay? And when you talk about ICU care, that's where you start talking about the different knobs here and change the knobs up and down and what we want to do to fix, to get the patient better or get more capture or less capture, okay? And you talk about that more in MedSurg2. But right now, you just got to talk about these are the pacemakers. They're for bradycardias, and I'm really worried about sensitivity, which is coming up when we talk about failure to sense, for instance. Okay. The other option we kind of mentioned was a permanent pacemaker. If the transvenous pacer is in place for 24 hours, 48 hours, and they're not getting better, they have sixth sinus syndrome, and they're 86 years old, and their AV node is gone, then it's time to place a permanent pacemaker, right? So sustained sinus bradycardia. So before we had sinus bradycardia, we have bradycardia, and we put on a transcutaneous pacer. And now it was sustained. It was more than 2 hours. So we put them on a transvenous pacer. And now it's sustained. Right? It's not going away. Now it's time for a permanent pacemaker. And it's the cardiologist that kind of makes that decision. Okay. So it's going to be the modes, the same as TVP, but we can also get really complicated when we talk about different modes of pacemakers, right? So the other thing that's cool that we can do, since we're in there, we're going to put this permanent pacemaker in there. We can place what's called the AICD, and that's going to shock them if they have a lethal rhythm. So it's going to be able to not only sense their intrinsic activity, it's going to say, whoa, that's VTAC. Look at that. I'm going to go ahead and shock them out of that VTAC. Okay? Because sometimes patients that have bradycardias also have like CHF, for instance. And when you have CHF, you're at risk for MIs, and we have MIs, you have VTAC, for instance, or VFib, and it will shock them out of that. And when it sees like a PEA or it sees asystole, it's not going to shock them. It knows what to do, okay? So that's what the AICD is for. And it's usually when your EF is less than 30%, that's when they would then get a PPM AICD combo, right? AICD stands for Automatic Internal Cardiac Defibrillator. All right, so it does what this machine does, right? Our Zoll machine down here defibrillates and it paces, right? We talk about defibrillation a lot with ventricular rhythms, and the pacing is what we're talking about with that it's doing at this point. So if they get pacemaker placement, and they get a permanent pacemaker placed here, you have to know what to tell them afterwards, right? What's the teaching that they should know after they get this PPM placed, right? This generator, again, it has a battery life of 5 to 8 years. Sorry, the newer models, they have, batteries are getting better nowadays, so it's lasting a little longer. But it's placed in a sub-Q pocket, and it's right here. So we want this pocket to heal. We don't want them to be doing a lot of activity afterwards, so we want to make sure that is, in place and heals up pretty well, and therefore it's going to hopefully, continue its normal function, right? These wires are introduced and then placed in the right ventricle. Sometimes they can place in the atrium if it's an AV paced pacer, but V pace is the most common. And again, it can be atrial, ventricular, dual chamber, which is A and V. And then we have an upgrade. We can pay for the little deluxe package, little Lightning Lane Plus, right? We can go ahead and get the AICD also in there, right? I see you have bradycardia. Your bradycardia is caused by DI, right? Drugs, ischemia, electrolytes. It wasn't drugs or electrolytes, it was I for ischemia, right? So you are at risk for an MI in the future. MIs have arrhythmias like VTAC, VFib. So let's go ahead and put an AICD in you as well. And it's really indicated with those that have low EF or a history of VTAC, VFib. So it's a great way to do like a 2-for-1, okay? So what are complications, right? What are complications of permanent pacemaker placement? It can maybe not heal well. So how do you make sure it heals well, heals good? It got to be put in a sling overnight, okay? Is this sling for 2 weeks until this thing heals over here? No, it's for 24 hours, maybe 48 hours, but basically sling overnight is what to make sure that they're not moving this pec muscle that's underneath, right? So that's going to that could potentially dislodge the pacemaker and break the leads that are going to the heart. Okay, so after that, it's going to be about 2 to 3 weeks of healing after they have that sling overnight, or maybe 2 nights at the most. And then for 2 to 3 weeks, they're going to keep it, take it easy. What are they doing for 2 to 3 weeks? No weight bearing, no lifting more than 5 pounds, definitely not more than 10 pounds, right? No pushing or pulling. You learn this if you came from OB, about postpartum. It's the same thing, right? You don't lift anything more than a baby, right? So more than 5 pounds, right? Don't raise your hands over your head. Don't be doing the YMCA, right? That's not recommended, or Pink Pony Club, or whatever you want to do, right? So clearance is needed for driving, right? So you can't be like driving all of a sudden, like you have to make a left turn, and then there goes your pacemaker, and then that's not good. So they have to usually at their follow-up visit in about 14 days or 3 weeks, 2 to 3 weeks. That's when they say, okay, you're cleared for driving as well, right? It's healed up nicely. The pacemaker's working. You can go ahead and continue driving at this point, right? Also, you don't want the pacemaker to not be working, and then they're going out driving. Then they get altered, and they start going out oncoming traffic. All right. So the leads, after a while, they can fracture or dislodge. So that's the idea that we have to be looking at. They're going to be symptomatic when this happens, and we have to look at the pacemaker and we actually interrogate it. Right. You get a little heat lamp going. You get the little good cop, bad cop activity, and you assess what the pacemaker is doing. Right. It's literally like a little device that goes on the pacemaker, and it connects to a guy in Boston, and he decides what to do with it, right? And he can actually change the settings from Boston to fix the pacemaker. Or he says, oh no, that battery's gone, you have to get that replaced, okay? So leads can fracture or dislodge, right? And it might send like aberrant shocks, like might send weird shocks because it's trying to go down this wire here, but if you have like a lead that's fractured, it could send another impulse all the way down on top of it, right? Because you want to have if electricity works, right? You want it to be coded, right? You want to make sure it's going right to where it needs to go. If your electricity wires in your house don't have you have rats chewing on it, it's going to cause fires to happen, right? So to make sure those leads are intact. Okay, and we'll talk about failure to sense and failure to pace on the next slide, right? So routine checkups are needed to make sure the pacemaker is working, that we don't have these issues of failure to pace or failure to sense. Okay. And then what else? It's a battery life, about 5 to 10 years, right? And if they get an AICD in place, they get that 2-for-1 deal. They got the AICD generator also. It might shock them. They won't know when it happens. But if during the first 1 year, about 50% will receive a shock. It's like, hey, we're gonna put this in your body, and it might shock you. It might be 1 in the morning. You don't know. You could have a lethal rhythm, or it could just be the thing doing its normal job, right? So it's a flip of the coin whether they're just gonna get shocked all of a sudden, right? And it could be while they're driving too. So it's something that does happen. So a 50% chance that your AICD will just shock no matter what. If it's shocking all the time, that's a problem, right? That means that they probably have a lethal rhythm. They need to come to the ER to get investigated. Okay, so one shock, up to 80% of patients, I said 50%, but 80 joules, right? 50% will receive a shock, just all of a sudden they'll just get a random shock. Okay, oh, it's working. So next, so additional teaching that you'll do for these patients is the programmed rate. They could know what it is, but they can have a little medic alert bracelet about what's going on, and it has what their pacemaker model is, and that pacemaker model will tell you if it's MRI compatible. So it will tell you if they are able to get an MRI or not. It tells you if they, and most newer ones are MRI compatible. It'll also tell you what mode they're on, and it might tell you what the manufacturer is. So we can call the manufacturer, hook up at both hospitals have a pacemaker interrogation kit where they can figure out what's going on with their pacemaker when they connect to that guy in Boston for Boston Scientific pacemakers, right? So the program rate should be maybe set at like 60 or 50, depends what the cardiologist says, and they'll tell them to take their pulse for about a week. Make sure that your heart rate is actually 50 or 60. That means the pacemaker is working. If the heart rate's 40, the pacemaker is set to 60, that means the pacemaker is not working. Okay, so if there's any variation, they should be calling somebody, and they need to wear a medic alert bracelet so they know that they have a pacemaker in place. It used to be that pacemakers were no good with microwaves. That's since been not disproven, but we have newer pacemakers that are microwave compatible. Don't put your patient in a microwave. All right. If they are traveling, right, they're going to make sure their magnets are still enemies of pacemakers. We actually have magnets that deactivate a pacemaker. Like an AICD shocking. It's like, oh, stop it. We put a little magnet that's located in one special spot that we all should know, right? And so it's going to be right there, and it's go on the patient's chest, and we hang that magnet right over them. It looks like a donut, right? And it sits right there, and it deactivates. You just put it on the patient's chest, it deactivates the pacer, and the pacer stops working 100%, right? It manipulates the servos and makes it so they stop firing, right? Or so that is, should they be in contact magnets? No. So TSA, they have to be aware. What does MRI stand for? Magnetic resonance imaging, right? Some pacers are MRI compatible, so we have to know which one's which, right? So that's important teaching based on what their card says from the pacemaker manufacturer when they get it implanted, right? High voltage radar machines, really, really high, not like 5G antennas, but it's not, there's no conspiracy theories going on, but like they shouldn't be living next to like a huge satellite dish. That probably wouldn't be the best idea. They should not be an arc welder. That should not be a good profession. They need to change professions at that point, right? And then signs and symptoms, you got to teach them. If you feel any chest pain, shortness of breath, hypotension, right? You feel confused. So you could go through the motions, but basically you can also inform the loved one that's there what if they have if they're feeling get more confused, they're feeling a lot more fatigued and weak, they're sleeping all the time. These are signs of poor cardiac output and signs their pacemaker might not be working. Okay, so we have to hook them up to our EKG, and we can assess if we are seeing pacer spikes with every single beat, right? If we're saying, well, there's no pacer spike there, then that might be a failure to pace or failure to capture or failure to sense. So we have to look at these pacer spikes. If there's no pacer spike, that's actually called a failure to pace, okay? And we'll talk about that on the next slide. The cool thing nowadays is they have generator-less or lead-less pacemakers where they just put a little device that just kind of sits right there, the right ventricle, and does all the things of pacing. So they don't need the generator, and it's called a micro. What do they call micro pacers? There's a brand name for it, but it doesn't have that huge generator problem like we have with these guys. Okay, so that's the idea with pacemaker placement. That this was a lot easier than the pacemaker modes, right? But it's the pacemaker is placed, and once it's placed, these are the teaching that we do for them. So the last piece on pacemakers is the pacer failing. So it can fail in 3 ways. So the 3 ways it can fail are failure to capture, failure to pace, or failure to sense. So obviously failure to pace is the worst one. That's why it's in dark red and highlighted, right? So failure to pace means my pacemaker is not pacing. And what should happen when my pacemaker paces? I should see pacemaker spikes, right? So I got a spike, and whoop, where's my spike at, right? So I have failure to pace means failure to see a pacemaker spike on my EKG strip, okay? And then what's going to happen? The underlying rhythm will be there. And what's the underlying rhythm here? That is idioventricular. That's probably why they had the pacemaker placed in the first place. Okay, so that is failure to pace, is where there is no pacer spike whatsoever. And why is it not pacing? It's not the patient's fault, right? It's not like they were the ones that caused this issue, right? So the pacemaker battery failed. The battery fails, that means they're not going to get any pacer spike because there's nothing being generated. There could be a hardware problem where there's a complete lead fracture. The lead has completely fractured. The signal's being sent, but it stops where the wire broke, and therefore there is no capture. There's no pacing happening. Does that make sense? Right? So either the battery has failed or the wire has completely broken. Okay? So there's no contact with the ventricle. Could be another reason. This lead could have just kind of traveled out. And it could be sending little impulses, right? But it's not in contact with the ventricle. Therefore, it's going to be a failure to what? Failure to pace. Okay? It could be a setting problem as well, where the settings are not correct, right? So the settings meaning that we're looking at sensitivity, because remember that first slide was really confusing, right? All that was revolving around sensing. And right here, we're usually sensing the ventricles. That's the most common pacemaker we look at. The most common thing we're sensing being the ventricles. So it could be that our gate, our fence, is way too high. If the fence is way too high, that means that, is it going to pace? No, it's like, I didn't see anything. That's why I didn't pace you, right? I didn't pace you because there's nothing to pace. I didn't sense anything. Therefore, I went and didn't send any kind of impulse down into the heart, right? So it is what? It is undersensing. It is not sensitive. Is where it gets confusing. It's like, well, what does not sensitive mean? Not sensitive means that I don't respond to things, right? So if you think of the boyfriend analogy, right? So my boyfriend is not sensitive, right? His fence is way up there. He puts all of his defenses. He is not sensitive to my feelings. He doesn't want to do things, right? So he is a not sensitive because his sensitivity is what? Is it way too high? Well, I don't know, the fence is high, but it's called low sensitivity, right? He has very, very, very low sensitivity. He does not care what's going on, right? Because the fence is way too high. His emotions are, I don't know, what's the word? They're like blocked. Yeah, so they're not looking at anything, right? They're not caring, okay? So that is called a less sensitive or not sensitive, okay? And they cannot see any intrinsic activity. They can't see what's going on. Okay, and that would be failure to pace. So that fence is all the way up there. It's not going to pace because of a setting that we set on the pacemaker itself. We set the sensitivity way too what? Low or high? We set the sensitivity way too low, right? We said way to the point where they don't care at all, right? You can think of it as like caring. And then we have going one step before failure to pace, right? We're going to see a failure to capture, right? And capture means that we have captured the heart. Right? So we are capturing. That means we have pacer spikes, right? But we did not capture. So what happened here? There's pacer spikes. It's pacing. It's not failure to pace. It's failure to capture. The pacer spike it got generated, it went down there, but it wasn't enough to capture the heart, right? It did not create a QRS complex, basically. Okay, so failure to capture, we weren't able to capture the atrial ventricles, whatever our pacer was set to, and so the pacer spike is present, but there's no P wave or QRS afterwards. So we're seeing pacer spikes, they're there, but there's nothing following it. Okay, and why would that happen? Well, it could be with the pacemaker, there's a lead fracture. It's not to the point where it's completely broken and there's no impulse being traveled. It's where there's a loss of impulse, right? So it's fractured right here. So some impulse went through, but some of it got lost, right? So we lost some of the impulse, and that impulse, that milliamps, was not enough to reach action potential thresholds, and therefore our heart did not get captured. Right? So lead fracture is an incomplete voltage delivery versus a complete lead fracture. So we have no contact with the heart chamber. There's due to scar tissue, right? There's still, the pacer activity is still there, but we're not seeing the heart getting captured with every pace or spike. Okay? It could be a weak battery, not a dead battery. A dead battery means no pacer spikes. A weak battery means I have pacer spikes, but it's not enough to capture the heart. Okay? And then it could be an issue with the patient. So the lights are super high. You know, our electrolytes can affect the membrane action potentials and such. So if they're super hyperkalemic, you could send a pacer spike down, but it's not going to cause that ventricle to depolarize because all the equilibriums are thrown off because the electrolytes are crazy, right? Or they have scar tissue from an MI, or they have drugs on board, right? They overdose on their beta blockers, they overdose on the amiodarone, for instance, and that causes so the heart is not able to respond to the pacemaker. Okay, so there is a pacer spike. It's there. You can see in the EKG. You can see that little deflection because it's energy that we're detecting, but there is no capture of the heart. Okay. So that's failure to capture and failure to pace. Down here, we're doing the same thing. I just kind of summarize what's up top, right? So last thing is failure to sense. Failure to sense is where we have what? We are way too sensitive, right? You have a boyfriend that wants to do everything with you. I need space. No, let's go to Santa Monica Pier. Let's go to the ice cream shop. Let's go to the Thai food. Let's go over here. And you know, tonight we're going to go out and we're going to see the stars. We're going to drive up the coast, right? It's like, oh my gosh, you got to back off, right? You are wet. You are way too sensitive, right? So too sensitive. They're detecting every single impulse and they are responding to it, right? So, are you okay? Are you okay? I'm going to text you. Are you okay? I'm going to send 42,000 emails. I'm going to send 60,000 texts, right? They say, hey, you haven't texted me in 7 minutes. Let me go ahead and text you again. Okay? So the sensitivity is way too high, right? They have too much sensitivity, right? They're too sensitive. So the fence is way too low, right? So it's like, well, didn't you say it was high? That's why I have to think of its sensitivity is whether you are sensing things or not sensing things, right? So you're not sensing things, you're not going to pace them. If you are sensing everything, that is failure to sense. Okay? So failure to sense means we're responding to any kind of electrical activity that the heart is throwing off. We're going to send pacer spikes. And that is dangerous because what happens when you throw a pacer spike on a T wave? It's caused a form of VTAC called torsades, right? Or polymorphic VTAC, right? So the setting is too low, so we are over sensing. And there's actually a little dial on our pacers, our little dial here, and you can turn it up or down. So that's where they say where you turn it up or down on sensitivity. And we'll talk about that more, but that's beyond this course. Okay, you might talk about that in MedSurg2. But you have to know that sensitivity is either too high or too low. I'm too sensitive. I'm responding to every single thing that's going on, or I'm not sensitive enough. Right? I have low sensitivity. I am not responding to anything. I am shunning the world. Okay, so why would this happen? Why would you have failure to sense? It could be because there is voltage, maybe is just escaping down this fractured lead. That could be a reason, but really it's a problem with the settings on the pacemaker. Okay, so I have a sensor problem. I'm not sensing things adequately. I could have a hyperactive myocardium that's responding to everything, but more commonly than not, it's because of a sensitivity issue, right? So we look at sensitivity, right? So here we talked about the EKG findings briefly, that they have either a pacer spike or no pacer spike, or have too many pacer spikes. If they have too many pacer spikes, that's called what? That's failure to sense, failure to figure out what's going on, right? Failure to capture means I have pacer spikes, right? But it's not capturing the heart. It's not causing a QRS to be affected. Whereas failure to pace is where they have no pacemaker spikes. Okay, those are my EKG findings, and we're going to do some practice EKGs. Okay, so what are the sensitivity problems? So we talked about that in detail. And then is it a pacemaker problem or is it a patient problem? Right? In failure to pace, it's not a patient's problem. It's just the pacemaker is failed or a lead has completely fractured. There's something wrong or it's been dislodged, right? Whereas failure to sense means that it is usually not a patient problem. It's rare. It's usually a sensitivity issue. We've cranked the sensitivity up way too high. Our boyfriend is way too sensitive, and they're responding to every single P wave artifact or anything that's being thrown off, and is throwing pacer spikes out there willy-nilly. So we're going to do some practice problems for pacers, right? So you're looking at, is it V-paced, AV-paced, means that it's working, or is it failure to pace, failure to sense, or failure to capture? Those are our three options, okay? So what's number one? What do we got for number one here? I got pacer spikes every single beat. It's working, right? So that's called, this hasn't failed at all, it's working. It's called ventricular paced, it's V-paced, okay? So V-paced is a pacemaker that's working, right? You have a healthy patient, they are working, right? Not every pacemaker patient is like, oh, you have a problem going on, right? So it's something we want to assess. Oh, you're paced. Let me look at your EKG. Oh, it looks like there's a pacemaker spike with every complex. You're good, right? What about this one? We got pacemaker spike, pacemaker spike. It's not AV paced. Or we got a little pacemaker? Yeah, I guess you could argue there's a pacemaker spike right there too, right? It's got atrial pacing and then a P wave, ventricular pace, and then a QRS complex. Okay, so that would be called AV paced, right? Now this one is also pacer spike, pacer spike, pacer spike, pacer spike. So pacer spike P wave, right? And then pacer spike QRS, right? And if a pacer is depolarizing the right ventricle, it's going to be super wide because it's going through all the little side streets to depolarize that ventricle. So we call this what? A-paced, B-paced, or AV-paced? It's AV-paced, right? There's no problems happening. So it's one of those three options, A-paced, B-paced, or AV-paced. All right, what's this one? Number 4. I got pacers spikes, so it's not failure to pace. Failure to pace means no pacer spikes, right? So it's either FTS or FTC. Is it failure to capture or failure to sense, right? So this is failure to sense. Look at that pace spike right on the T wave. That's a problem. So that means my sensitivity was what? Way too high. I'm way too sensitive, right? I'm sensing the T waves. Like, oh, T wave. Oh, I'm going to go and pacer spike, right? That is not appropriate, right? That means we need to increase the fence. So this is failure to what? Failure to sense. All right, what about number 5? I got a pacer spike, and then asystole, right? So that's why I had a pacer in the first place, like I told you, right? So I have a absent pacer spike, therefore it's called failure to, I heard capture pace, or capture, right? Failure to pace, right? Failure to capture means I have pacer activity, but it did not capture the heart. Okay, so the next one, I have pacer spikes, right? It's not failure to pace because it's pacing. It's not failed, right? But I had no capture, right? That was failure to capture. Well, the next number 7. So it's V-paced for sure. I got a ventricular spike and QRS. Ventricular spike, QRS. Now, can V-paced patients have ectopy? They could, right? So you can argue, you would kind of look at the patient to see if they were okay or not. You could argue this is V-paced with quadrigeminy, or you could say it is failure to pace. Maybe this was intermittently, they were missing a pacer spike, right? And their little idioventricular rhythm was coming in, okay? So V-paced the PVCs, or you could argue it's failure to pace. Again, on the test, I'm not going to give you something like this. It'll be super clear whether it is paced or whether it is not working. Okay. What about this one? What's going on here? Like a pacer spike, pretty even. It's not failure to pace for sure. That's just V-paced. Okay. Why is it not AV paced? There's only one spike for every complex. If there's 2 spikes for every complex, you have AV pacing. Okay, so I would see a pacer spike before the P wave, which is kind of all over the place. That's probably why they had a pacer replaced in the first place. They probably had a second degree type 1, right? See how that PR interval is all over the place? right? It's getting longer, and not today, not dropping. Here, pacer. All right, what is this? So we got a pacer spike that is MIA. We got a pacer spike here and here and here, but what happened here? Right, that is failure to pace. All right, what's the next one? I got 2 spikes for every complex, and everything looks copacetic. There's nothing dropped, nothing extra, right? So that is called AV pace. What about the next one, number 11? That's irregular. If I get something irregular, something got dropped. So I got dropping here, I got a drop here, and I specifically have a drop because I had pacer activity. So it's not failure to pace. Failure to pace means no pacer spike, where it would be expected. So I have a failure to capture, right? The pacer spike is where it should be. It's just not capturing the heart. Okay. What about the next one, number 12? So AV or V? So there's beautiful P waves, right? So that's not atrial paced. That is V paced. All right. Every V paced rhythm technically has wide QRSs. Okay. If it's just purely atrial paced and it's going down the normal pathways, it could have a bit narrow complex. What about number 13, top right? What's happening there? That's definitely failure to pace. I'm supposed to have a pacer spike right there, but instead I got asystole, right? So and then it kicked back in over here. So it's kind of not working right well. So I could have a lead that's fracturing, and all the impulses are getting lost briefly, right? Or maybe it's dislodged, or maybe the generator is failing. It's on its last effort, last leg. So that's failure to pace. What about 14? There, look at that. You got atrial right before the P wave. Look at that nice narrow QRS complex because it's going through the normal pathways down the heart. It wasn't in the right ventricle pacing send a huge impulse from the right ventricle, which would cause a wide QRS. All right, so that's just pure atrial paced or A-paced. What about 15? So good. We got pacer spikes. It's like, well, pacer spikes should be before the QRS, right? So it is what? Too sensitive or not sensitive enough? It's an overly sensitive boyfriend, right? So it is over-sensing. It is seeing activity. It's like, oh, you want a pacemaker right here? Oh, there's pacemaker there. So it's not doing its job. It's failing to sense, right? It's actually sensing great, but it's called failure to sense, ironically. Okay? So next one, number 16. So I lost, what happened here? Right? So it did not pace at all, right? So that's failure to pace. Failure to capture would be a pacer spike would be there, right? And I would have no activity. I would see a pacer spike there if that was failure to capture. Failure to pace means no pacer spike, failure to pace. What about 17? Good. So just like I just illustrated, right? I have pacer spikes, but why was there no activity? It could be a weak battery, not a dead battery, but a weak battery. I could have a fractured lead where some impulse is getting through and some of it is leaving, and that impulse that does get through is not enough to depolarize the ventricles, right? It could be a patient who is hyperkalemic and hypercalcemic and hypermagnecemic, right? And also is extremely ischemic with scar tissue. The pacer is working, it's sending the impulse, but the patient's heart is not receptive. So number 18, what is this? Good. So we have an absent pacer spike. No pacer spike means failure to pace. That's the easiest one, right? If I don't have a pacer spike, that is failure to pace. Next one. I have pacer spikes, but it did not capture the heart, right? That's failure to capture. What about 20? Good. Is it atrial paced, or you could argue those are P waves there. It looks kind of like V paced, really, because I got Y QRSs. That one's a tricky one. So you could argue, yeah. Oh, I guess there is a little pacer spike there. All right, so we missed little pacer spikes there. You can argue we had poor internet connection up there, right? So we had little pacer spikes, the atria, and a pacer spike in the ventricles, right before the QRS. All right, next one, 21. Good. So we're missing complexes there. Looks like it was an atrial pacer, right? And it was going down the normal pathways. That's why the narrow complex. But we have failure to capture. What about 22, top right? Yeah, just that's this one that's working, right? It's 21 that's not having problems, right? So it's a normal A-paced. What about 23? Good, failure to sense, right? It's doing its own thing. That's FTS, right? It's seeing failure to sense. It sees activity. It's like, oh, you want to go out for ice cream? And then they go out and say, oh, you want to do? Let's go to the movies. And then they go again. It's like, oh, let's go for popcorn. Oh, let's go to the let's go for a walk, right? So, but the danger is you can just irritate them, and he's like, torsades, right? So, and you could go into polymorphic VTAC if you have a pacer spike on top of a T wave. All right, and 24, what's happening there? Good, that's very clear. AV, atrial spike, ventricular spike, atrial spike, ventricular spike. So that's AV based. What about 25? That's also looking like failure to, look at that guy, right? That's also failure to sense. It's not seeing, it's overreacting, right? It is over sensing. It is seeing way too much activity. So it's failure to sense. Next one. Good. There's pacer spikes, but some of them don't have activity following, right? So those lack of activity means, if there was no pacer spikes, I would have failure to pace. But if there is pacer spikes and nothing following it, that is called failure to capture.